Welcome to the Funnel Effect.
Glad to be here.
So for today's deep dive, we're digging into a really pivotal piece of medical literature.
Oh, yeah. A total game changer.
Right. It's an article published in the New England Journal of Medicine, specifically from September 19th, 2013.
Seems like a while ago, but the ripple effects are still huge today.
Exactly. It's titled Randomized Trial of Preventive Angioplasty in Myocardial Infarction. And we need to list out the sources and the key authors here so everyone knows exactly where this data is coming from.
Right. The team behind this was incredible.
Yeah. So it's David S. Wald, Joan K. Morris, Nicholas J. Wald, Alexander J. Chase, Richard J. Edwards, Liam O. Hughes, Colin Berry, and Keith G. Oldroyd. And they published this on behalf of the PREMI investigators.
PREMI, right. That's the acronym we'll be using a lot today.
Right. So to really hook you into why this matters, I want you to picture this high-stakes scenario.
Okay, set the scene.
You are a surgeon, right?
And
your patient is lying on the operating table in a brightly lit catheterization laboratory.
The cath lab, yeah.
Yeah, the cath lab. And this patient is actively dying from a massive, life-threatening heart attack.
It is literal life or death in that moment. High stress.
Extremely high stress. But you manage to thread a catheter into their heart, you unclog the main blocked artery, and you essentially save their life.
Which is an incredible feeling, obviously. You did your job.
You did your job, but before you pull your instruments out, you inject a little more of that contrast dye, and you notice something else.
Uh-oh.
Right? You see that two other arteries are like 60% blocked.
Yeah, which is not great.
So here is the real-world dilemma. Do you fix those right now and risk killing this highly unstable patient on the table? Or do you stitch them up, send them to recovery, and basically wait for the next heart attack to happen?
I mean, it sounds like a totally straightforward question of plumbing, right? Like you see a clog, you fix it.
Exactly. Just snake the drain while you're in there.
Right. But that specific scenario absolutely fractured the cardiology community for decades. I mean, it was a massive debate.
Wow, really?
Oh, yeah. And we're going to unpack how this single paper from 2013 provided an answer so definitive, it fundamentally altered global medical protocols.
That's crazy.
For anyone listening who assumes medical guidelines are just, handed down on stone tablets, this is a masterclass in how evidence actually shapes things.
And sometimes completely shatters the status quo.
Exactly.
So we have to set the baseline first. The medical emergency that triggers this whole dilemma is called a STEMI.
Right. STEMI.
Right, which stands for an acute ST segment elevation myocardial infarction.
Which is a mouthful. But basically, for those familiar with cardiac events, this is the big one.
Yeah, but let's look at the actual mechanism of what is happening inside the patient's chest during a STEMI.
Yeah.
Because it's not just a pipe slowly clogging with rust over decades until it finally seals shut, right?
No. The slow clogging pipe is a really common misconception.
Yeah.
I mean, in a STEMI, the pathology is actually acute and violent.
Violent. Okay, explain that.
So you have a coronary artery that has a buildup of plaque. And this plaque has a lipid core, basically fat, and it's covered by a fibrous cap.
Okay, so a core of fat with a little lid on it.
Right. And in a STEMI, that fibrous cap physically ruptures.
Wait, so it's more like a blister suddenly popping inside the wall of the artery.
That is actually a much more accurate way to visualize it. Yeah, blister popping.
Wow.
And when that blister pops, it exposes the highly thrombogenic material inside the plaque to the bloodstream.
Thrombogenic meaning it causes clots.
Exactly. The body's immune system absolutely panics. It views this rupture as a massive traumatic injury and instantly triggers a coagulation cascade.
Because it's trying to heal the cut, basically.
Right. Platelets rush to the site, they bind together, and they form a localized blood clot, a thrombus, that completely occludes the vessel.
So it just shuts the whole artery down instantly.
Instantly. The blood flow downstream drops to absolute zero. And the heart muscle that relies on that specific artery begins to suffocate and die within minutes.
Man, that is terrifying. So the standard treatment here is emergency percutaneous coronary intervention, right? What they call PCI.
Right, often just called angioplasty or stenting.
So the cardiologist snakes a wire up through the wrist or the groin, finds that specific ruptured blister, what the paper calls the culprit or infarct artery, and deploys a stent to crush the clot against the wall.
Yep. You prop the artery open with this little metal mesh tube.
Right. And that part is not up for debate at all. Fixing the culprit artery is a total no-brainer to save the patient's life.
Absolutely. No one disagrees on that.
But here is the massive complication. These patients rarely just have one bad artery, do they?
They almost never do. I mean, the systemic conditions that lead to plaque buildup in the first place, Things like hypertension, hyperlipidemia, systemic inflammation, diabetes.
Those don't just target one isolated spot.
Exactly. They don't just target a single millimeter of one artery.
Yeah.
So if the environment in your bloodstream has caused a massive plaque rupture in your left anterior descending artery, it is highly probable your other arteries are also a mess.
Like your circumflex artery or your right coronary artery.
Right. They're likely full of atherosclerotic plaque too.
Okay, so while the cardiologist is inside the heart fixing the STEMI, they inject contrast dye to map out the vasculature, right?
Yeah, you have to see what you're doing.
Right, and they see these other blockages in what we'll call the non-infarct arteries, meaning the arteries that aren't actively causing the heart attack right this second.
Yes.
And we're talking about narrowing of 50% or more in these other arteries.
Significant blockages, yeah.
So I want to use a burning house analogy here to really ground this for you.
Okay, let's hear it.
Imagine a house where one specific room is completely engulfed in flames. That room is your culprit artery.
Right.
The fire department kicks down the door and turns the high-pressure hoses directly on that room, because if they don't, the whole house burns down.
Makes sense. You have to stop the immediate threat.
Exactly. But while they are standing inside with the hoses running, the firefighters look down the hallway and see two other rooms filled with thick, black smoke and smoldering embers.
Okay, I see where this is going.
Those are your non-infarct arteries with the 50% blockages.
The smoldering rooms.
Right. So the dilemma becomes tactical. Do the firefighters drag the hoses down the hall and douse those smoldering rooms right now, risking structural collapse by staying inside a weakened house?
Right, because the patient is highly unstable.
Exactly. Or do they put out the main fire, pack up their gear, leave the property, and just pray the smoldering rooms don't spontaneously combust later?
It's a great analogy, because from the outside, spraying down the smoldering rooms seems like pure common sense.
Right. You have the hoses inside, you see the danger, you neutralize the danger.
But as you know, medical history is basically a graveyard of common sense interventions that turned out to be physiologically disastrous.
Yeah, intuition in medicine can be super dangerous.
It really can. And that is the exact tension that created two fiercely opposed camps in cardiology leading up to 2013.
Right, so let's detail these two camps. You had the interventionists and you had the minimalists.
Yes. Let's start with the interventionists. Their philosophy aligns perfectly with your firefighters spraying everything in sight.
They wanted to fix it all right then and there.
Exactly. They argued that leaving a major blockage, like a 50% stenosis in a non-infarct artery, was basically leaving a ticking time bomb.
Especially inside a patient who had just proven they were highly prone to plaque ruptures.
Right. The logic is very sound on its face. If you leave a significant stenosis, you are leaving an area of disrupted blood flow, high shear stress, and vulnerable plaque.
So the interventionists firmly believed that failing to stent those lesions would guarantee the patient return to the ER months later with another massive heart attack.
Yeah, they wanted to perform what we call preventative PCI, stenting the smoldering rooms immediately to save lives down the line.
But then you have the other side, the minimalist camp. And we could also call them the guideline followers, because they actually had the official medical establishment on their side, right?
It absolutely did. They argued that less is more in an acute crisis.
And they were relying heavily on medical therapy instead of more surgery.
Yes, and I want to dig into that because they weren't just sending people home with a baby aspirin and a pat on the back.
Right. It's not like they were doing nothing.
Not at all.
Yeah.
They were using incredibly powerful systemic drugs. The pharmacological arsenal available to cardiologists is formidable.
So they're saying, we don't need metal tubes, we have chemical weapons.
Exactly. The minimalists argued we don't need to physically crush every piece of plaque with a metal stent because drugs can stabilize those smoldering rooms chemically.
Okay, so what exactly are they prescribing?
High-dose statins, for one, which do a lot more than just lower circulating cholesterol.
Wait, really? I thought statins just lowered your bad cholesterol numbers.
They do, but they also actively alter the biology of the plaque itself. They draw lipids out of the core and actually thicken that fibrous cap so it's much less likely to pop.
Oh, wow. So it physically hardens the blister so it won't rupture.
Exactly. Plus, they use beta blockers to slow the heart rate down, which reduces the sheer mechanical stress of blood pounding against the vessel walls.
Less pressure on the pipes.
Right. And then they use dual antiplatelet therapy heavy-duty blood thinners.
So even if a microscopic rupture does happen, the platelets won't clump together and form a lethal clot anyway?
You've got it. So The minimalists are essentially saying, we can put the smoldering embers out with chemicals. We don't need to risk dragging heavy equipment down the hallway.
And the risk of dragging that equipment down the hallway is pretty substantial, isn't it?
Oh, it's huge. The patient is currently experiencing massive physiological trauma from the main heart attack.
Their heart rhythm might be irritable, their blood pressure might be tanking.
Right. And putting a piece of metal, a stent, into a coronary artery is an inherently violent act to the blood vessel.
Because the body recognizes the stent as a foreign object.
Exactly. Until the body can grow a new, smooth layer of endothelial cells over that metal mesh, which takes months, by the way, the stent itself is highly thrombogenic.
Meaning the stent itself can cause blood clots.
Yes. This introduces the acute risk of stent thrombosis. If a clot forms on the newly placed stent, you have instantly created a brand new, potentially fatal heart attack while the patient is still on the table.
Man, that is a terrifying catch-22.
It is. So the minimalists argue that exposing an already unstable patient to extra radiation, extra contrast dye, and the acute risk of stent thrombosis for a blockage that wasn't actively killing them, well, they saw it as a violation of the primary directive. First, do no harm.
What really fascinates me is that the major authoritative bodies in medicine entirely sided with the minimalists prior to 2013.
Yes, the European Society of Cardiology, the American College of Cardiology, the AHA.
They all explicitly recommended against preventive PCI during the initial emergency procedure.
Their overarching philosophy was to stabilize the acute emergency first.
The rule was basically fix the culprit artery, get the patient off the table alive, and manage the rest with pills.
Right. And they believed that if a patient continued to have chest pain weeks or months later, despite the heavy medication, you could bring them back for a staged procedure.
Meaning a totally separate surgery later on?
Exactly. Because elective stenting on a stable, rested patient has a completely different, much lower risk profile than emergency stenting on someone in the throes of a massive infarction.
I mean, I hear that, but I have to challenge the logic of those guidelines from a purely mechanical perspective.
Go for it.
If you already have the arterial access in the patient's wrist, you already have the catheters threaded all the way up into their ascending aorta, and you are literally staring at the blockage on the screen.
Right, the tools are already inside the heart.
Exactly. Why on earth would the guidelines tell you to stop, pull all that hardware out, let the puncture site heal, and then intentionally subject the patient to a second invasive procedure months later?
It seems counterintuitive.
It seems wildly inefficient. Not to mention, you're giving them a second round of puncture risks, a second round of radiation, and the mental agony of knowing they have a clogged artery left inside them.
You're highlighting the ultimate clinical debate of that era. Is the immediate compounded risk of an extended emergency procedure higher or lower than the cumulative risk of two separate procedures separated by months of anxiety?
And I'm guessing they just didn't know the answer for sure.
They didn't. The medical community couldn't answer it with observational data.
Why not? Didn't they have thousands of patient records to look at?
They did, but retrospective studies were basically useless here because doctors just cherry-picked the data that supported their existing bias.
Ah, of course.
Yeah, if a mentalist lost a patient to a secondary heart attack months later, the interventionist said, see, you should have stented them on day one.
And if an interventionist lost a patient on the table because the procedure dragged on too long?
The mentalist said, see, you shouldn't have been poking around in the smoldering rooms. It was a total stalemate.
So to break that deadlock, Dr. David Wald and his team realized they needed a gold standard randomized controlled trial.
They had to engineer something completely bulletproof.
Let's get into the architecture of PRAME, because this wasn't a trial run in a calm outpatient clinic. This was trial by fire randomization.
It really was. PRAME was conducted between 2008 and 2013 across 5 centers in the United Kingdom.
And they enrolled 465 patients, right? Patients who presented with an acute STEMI and multivessel disease.
Correct. But the randomization process itself is what makes this trial legendary in the cardiology world.
The timing of the randomization is just wild to me.
Walk us through it.
Okay, so the patient is literally lying on the cath lab table. The cardiologist has just successfully stented the culprit artery and saved their life. And at that exact second, while the catheters are still inside the heart, the trial protocol kicks in.
Right then and there.
Right then, an automated system randomly assigns the patient to one of two fates. Group A gets preventive PCI. The computer tells the doctor to go ahead and fix any other artery with a blockage over 50% immediately.
Turn the hoses on all the smoldering rooms.
Exactly. Or they get put in Group B, no preventative PCI. The computer tells the doctor to leave the smoldering rooms alone, pull the gear out, and rely strictly on medical therapy.
Implementing randomization at the absolute climax of a medical emergency requires immense clinical discipline. It is so hard to do.
I can imagine. The urge to just follow your gut must be overwhelming.
It is. But they also had to protect the integrity of the data and the safety of the patients. So they instituted really rigorous inclusion and exclusion criteria to ensure they were comparing apples to apples.
Yeah, I was looking at those exclusions, and one of them is cardiogenic shock. Why exclude those patients?
Oh.
I mean, if they are the sickest, wouldn't they benefit the most from having all their plumbing fixed?
It makes intuitive sense, but cardiogenic shock is just a fundamentally different physiological state.
How so?
It means the heart muscle has been so severely damaged that the pump itself is failing globally. The heart cannot maintain enough blood pressure to perfuse the brain and other vital organs.
So they're just crashing entirely.
Right. In that scenario, all standard rules are suspended. The procedural risks multiply exponentially.
So including them would just muddy the waters of the trial.
Exactly. The investigators excluded them because including patients with such massive, chaotic baseline mortality would create too much noise in the data. They needed patients who were having a severe STEMI, but whose overall hemodynamics were stable enough to actually measure the long-term effect of the extra stents.
That makes sense. They also excluded patients with previous bypass surgery, right?
Right, because their cardiac anatomy has literally been rerouted with grafted veins. It's a totally different landscape.
And they excluded blockages in the left main stem, which is often called the widowmaker artery.
Yeah, because a 50% blockage there is treated as an absolute surgical emergency regardless of any trial protocol. You do not leave the left main stem untreated.
They also filtered out chronic total occlusions. Those are arteries that have been 100% blocked for a long period. Right.
Right, because standard stenting techniques often fail to cross those anyway. It takes specialized procedures.
So they really refined the patient pool down to a very pure, specific clinical scenario.
They did.
Okay, so how did they actually define a win or a loss for these patients over the next couple of years? What were they measuring?
They utilized what we call a composite primary outcome.
Meaning they bundled a few different bad things together into one metric.
Right. A negative event was triggered if the patient experienced death from cardiac causes, a non-fatal myocardial infarction. So another heart attack or refractory angina.
Okay, I have to challenge the inclusion of refractory angina in this primary outcome.
I knew you would bring that up.
I mean, compared to hard, undeniable endpoints like dying or having a massive heart attack, angina is just chest pain, right? Isn't that notoriously subjective in clinical trials?
It absolutely can be.
Like, a patient complains of a twinge in their chest, they get anxious, the doctor notes angina on the chart, and suddenly it's logged as a negative event against the minimalist group.
Right, which would artificially make the minimalist group look worse, just because their patients were complaining more.
Exactly. How did the primary investigators stop soft subjective data from polluting this trial?
It is the most common critique of composite endpoints. But the primary investigators anticipated it brilliantly.
What did they do?
They constructed a very rigid clinical definition for refractory angina. It could not be triggered solely by a patient's self-reported discomfort.
Oh, really?
No. The protocol demanded objective evidence of ischemia.
Meaning they had to physically prove the heart muscle was starving for oxygen, not just experiencing a muscle spasm or heartburn.
Precisely. If a patient in the trial reported chest pain, they had to undergo advanced diagnostic testing.
Like what kind of test?
Like a stress echocardiogram, where we look for actual wall motion abnormalities in the heart muscle while it's under load, or a nuclear perfusion scan, or an MRI to measure literal blood flow deficits.
Wow. Okay, so they had to actually see the problem on a scan.
Right. Unless the imaging hard confirmed that the smoldering room was actively failing to deliver oxygen to the tissue, it did not count as an event.
That is bulletproof.
It really tightens up the data. And on top of that, they use a single-blind methodology to eliminate investigator bias.
Single blind, meaning the patient knew what treatment they got, but the doctors evaluating them didn't.
Exactly. Obviously, you cannot blind the patient in this scenario.
Right. If you lie awake on an operating table for an extra 40 minutes while a doctor deploys 3 metallic stents into your chest, you know you were in the interventionist group.
Yeah, there's no hiding that from the patient.
But the independent committee of cardiologists who were tallying the final score, the ones reading the EKGs, analyzing the stress tests, and reviewing the death certificates, they were completely blinded to the patient's group assignment.
They had no idea if the chart they were reviewing belonged to someone who got the preventive stents or the medication alone.
So they engineered a trial that was virtually immune to standard statistical criticisms.
They really did. So the trial is running, the data is accumulating across 5 UK hospitals, and the whole cardiology world is basically waiting with bated breath.
But then, in January 2013, a dramatic intervention brings everything to a screeching halt.
Yeah, this is where it gets really cinematic.
The Data and Safety Monitoring Committee, these are the independent watchdogs who have the absolute power to kill a trial at any moment, stepped in and pulled the emergency brake.
We shut it down early.
Now, historically, when we hear a major clinical trial is stopped early, our brains immediately jump to a worst-case scenario.
Oh, absolutely.
We assume the experimental treatment was hurting people. I would assume the extra time on the table, the extra radiation, and the extra metal stents were causing a massive spike in complications, just like the minimalists warned.
That is the standard assumption. But the reality of PROMI forces us to completely flip the script.
Wait, so what happened?
The trial was not halted due to harm. It was halted because of overwhelming, undeniable efficacy.
Oh, wow. That is incredible.
The interim data analysis revealed a divergence between the two groups that was so massive, so statistically profound, that the committee concluded it was ethically indefensible to continue the trial.
Because to keep the trial running would require the investigators to intentionally randomize new patients into the minimalist control group.
Actively denying them a preventive procedure that was already demonstrably saving lives.
Exactly. Let's dissect the raw numbers that forced the ethics committee to pull the plug, because the statistics here are absolutely seismic.
Let's look at them. Over a mean follow-up period of 23 months.
Let's look at the minimalist group first. The patients who received the standard guideline recommended care of fixing only the culprit artery and relying on medication.
Okay.
Out of 231 patients in that group, 53 of them hit that primary outcome of cardiac death, another heart attack, or severe objectively proven angina.
That is a failure rate of 23 events per 100 patients.
So nearly 1 in 4 patients suffered a major cardiac event within 2 years.
Right. Now, contrast that with the interventionist group.
The ones who got the preventive PCI.
Exactly, fixing all the smoldering rooms immediately. Out of 234 patients in that group, only 21 hit the primary outcome.
Wow. That drops the rate to 9 events per 100 patients.
Yep. And when you run the math on that, it produces a hazard ratio of 0.35.
Let's put that in plain clinical English. That is a 65% relative risk reduction.
Yes, 65%. And the absolute risk reduction is 14 percentage points.
I want to really emphasize the sheer scale of a 65% relative reduction.
It's almost unheard of. To understand the magnitude, you have to look at the modern landscape of cardiovascular trials.
Because our baseline pharmaceutical therapies are already so good, right?
Exactly. Statins and blood thinners are incredibly effective today. So finding a brand new intervention that provides even a 10% or 15% relative risk reduction is considered a massive triumph.
A 15% reduction gets published on the cover of medical journals and slowly shifts the standard of care.
Right.
Yeah.
But a 65% reduction, that isn't just a shift, it's a paradigm-shattering earthquake.
It cuts through all the statistical noise and proves that the ticking time bomb theory wasn't just a theory at all. The smoldering rooms were actively killing people.
They absolutely were. And the overall composite number is staggering, but the true robustness of the primary data is revealed when you deconstruct the primary outcome into its 3 constituent parts.
Because if the massive risk reduction was driven entirely by the angina metric, even with the objective testing, skeptics might still argue the data was soft.
Exactly.
Yeah.
But the hazard ratios were virtually identical across every single hard metric.
I have the breakdown right here. For death from cardiac causes, the hazard ratio was 0.34.
Incredible.
For non-fatal myocardial infarction, it was 0.32. And for refractory angina, it was 0.35.
It's shockingly consistent.
It really is. That means if you strip away the angina data entirely and only look at the hardest possible outcomes, dying from a heart attack or surviving a second heart attack, the reduction in risk was still 64%.
And the p-value on that specific calculation was 0.004.
Meaning what, statistically?
A p-value of 0.004 translates to roughly a 1 in 250 chance that this divergence in outcomes happened by random statistical variance.
So it's basically undeniable.
The signal is undeniable. Furthermore, we must analyze the secondary outcomes, specifically the rate of repeat revascularization.
Meaning the patient degraded to the point where they had to be rushed back to the hospital to get another stent or undergo open heart bypass surgery.
Right. In the minimalist control group, there were 46 events of repeat revascularization.
And in the prevented PCI group.
There were only 16.
Wow. So the patients who didn't get everything fixed up front had nearly triple the rate of requiring a second invasive procedure later on.
This directly dismantles the establishment argument that waiting and doing a staged procedure later is safer or more efficient.
Clearly it's not. And there is another metric in the secondary outcomes that acts as a vital sanity check here. Non-cardiac deaths.
Oh, this is crucial.
Deaths from things entirely unrelated to the heart, like cancer, strokes, or car accidents. There were 8 non-cardiac deaths in the preventive group and 6 in the control group. Why does that slight parity matter so much?
It acts as the ultimate validation of the randomization process itself.
Because if the preventive group had, say, 0 non-cardiac deaths.
A statistician would argue that the randomization failed. They'd say the preventive group simply ended up with patients who were generally younger, healthier, and less prone to dying of anything.
Oh, I see.
But because the non-cardiac death rates were statistically identical, it confirms the massive survival benefit observed in the primary outcome was driven entirely by the mechanical intervention on the coronary arteries.
That makes total sense. Now, the minimalist camp facing these numbers would inevitably mount a defense based on pharmaceutical adherence, right?
Oh, without a doubt.
They would argue the control group only failed because they didn't take their medicine. If they had been perfectly compliant with their statins and their blood thinners, the chemical therapy would have matched the mechanical stenting.
It's the classic defense. But Table 2 of the PROMISE study completely nukes that argument from orbit.
Let's talk about Table 2.
Table 2 is arguably the most important piece of supplementary data in the entire paper. It detailed the precise medical therapy prescribed to both groups at the time of hospital discharge.
Proving what you guys call medical parity.
Exactly. And the adherence numbers are astonishingly tight.
I'm looking at them. For aspirin, it was 100% adherence in both groups.
Perfectly matched.
For clopidogrel and other powerful P2Y12 inhibitors, the critical antiplatelet drugs, it was also 100% in both groups.
And what about statins to alter the plaque biology?
95% adherence in the preventive group, 97% in the control group. Beta blockers and ACE inhibitors are all hovering tightly in the low to mid-90s across the board.
So this creates an inescapable conclusion for the medical community. The minimalist hypothesis that state-of-the-art medical therapy is sufficient to manage 50% stenosis in non-infarct arteries was unequivocally falsified in the context of an acute STEMI.
They couldn't hide behind the patients didn't take their pills excuse.
Not at all. The control group received the absolute pinnacle of modern pharmaceutical care. Their lipid profiles were suppressed, their platelets were inhibited, their heart rates were controlled.
Yet even with that chemical armor, leaving the physical plumbing problem unresolved proved to be vastly inferior to mechanically scaffolding the artery.
Right, the physical architecture of the plaque rupture essentially superseded the chemical stabilization.
That is a profound recalibration of cardiovascular theory. But I mean, we have to address the elephant in the cath lab here.
Which is?
Stenting 3 arteries takes significantly more time than stenting 1. It consumes more resources. And the minimalists weren't crazy to be terrified of the procedural risks. We have to weigh the actual biological cost of this success.
It's a fair point. The procedural downsides are meticulously logged in the study's supplementary data.
And they confirm exactly what the minimalists predicted regarding resource utilization, don't they?
They do. The preventive PCI group required significantly longer procedure times. And because the procedure took longer, the patients were exposed to higher doses of fluoroscopy.
Fluoroscopy being the continuous X-ray the cardiologist uses to visualize the catheters inside the chest.
Right, so prolonged radiation exposure for the patient.
Furthermore, mapping and stenting multiple vessels requires a significantly higher volume of radiopaque contrast dye to be injected into the bloodstream.
Yes, and this is where the nephropathy risk enters the chat.
Right, because contrast dye is essentially a heavy iodine-based liquid.
It's hard on the body.
When that heavy dye hits the kidneys, which are basically a delicate network of microscopic filtration tubes, it can cause the blood vessels inside the kidney to forcefully constrict.
Which starves the kidney tissue of oxygen.
Exactly, leading to acute kidney injury or what's called contrast-induced nephropathy.
which can require dialysis if it's bad enough.
And on top of that, a longer procedure means the catheter is spending more time scraping against the delicate inner lining, the endothelium of the aorta and the coronary arteries.
And every scrape carries a risk.
Every scrape carries a risk of dislodging a piece of calcified plaque, sending it up to the brain, and causing an ischemic stroke.
Exactly.
So, the million-dollar question. Did these guaranteed increases in radiation, dye, and mechanical manipulation translate into actual measurable harm to the patients in the preventive group?
This is the most brilliant, counterintuitive twist in the entire data set.
What happened?
They did not. Despite the longer time on the table, despite the increased radiation, and despite the heavier dye load, the rates of procedural complications were statistically identical between the two groups.
Identical. Wait, that defies the basic physics of risk exposure.
It really does, until you contextualize it within the evolution of modern medical technology.
What do you mean?
The rates of procedure-related stroke, major bleeding requiring a blood transfusion, and contrast-induced nephropathy requiring dialysis showed absolutely no statistically significant difference between the group that received the rapid single-vessel fix and the group that stayed on the table for the comprehensive multi-vessel overhaul.
How is that practically possible? Were the minimalists basing their fears on outdated data from, like, the 1990s?
In a sense, yes. If we extrapolate the meaning behind this lack of complications, it paints a picture of incredibly advanced modern cath labs.
Like the tools got better.
Much better. Today's contrast dyes are lower in osmolarity and far less toxic to the renal tubules than the dyes used 20 years ago. The catheter wires are infinitely more hydrophilic and maneuverable, which massively reduces endothelial trauma.
And I assume the doctors are just faster now, too.
Exactly. The interventional cardiologists themselves are vastly more efficient. The data suggests that the marginal increase in procedural time required by a modern, skilled operator to place 2 additional stents simply does not generate enough acute risk to outweigh the catastrophic long-term danger of leaving a vulnerable plaque untreated.
So the technology and the skill level simply outpace the old dogma.
They did.
So PREMI detonates in the pages of the New England Journal of Medicine. It provides an unassailable answer to a very specific question, backed by a massive relative risk reduction and identical complication rates.
A total victory for the interventionists.
But the hallmark of revolutionary science is that answering one question instantly spawns a dozen new, highly complex questions for the community to grapple with.
Oh, the ripple effect was huge.
Let's look at that ripple effect, because PRIME wasn't the first trial to suggest this, was it?
Actually, no. It is worth noting that earlier trials, notably the HELP-MI trial and the Politi trial, actually produced data hinting at this exact outcome, that preventive PCI was superior.
If the data was already out there, why did the European and American guideline committees ignore it? Why did it take PRAMI to break the consensus?
Because the medical establishment is inherently and rightfully conservative. They demand overwhelming proof before changing a global standard of care.
So what was wrong with those earlier trials?
They were heavily criticized for methodological flaws. Primarily, they lacked statistical power, meaning their sample sizes were too small to generate unshakable confidence in the results.
Too much noise in the data.
Right. Furthermore, they relied disproportionately on the endpoint of repeat revascularization,
which we discussed is a hugely biased metric. If a minimalist doctor knows they left a 50% blockage in a patient's chest, they are going to have an incredibly low threshold for rushing that patient back to the cath lab the second they complain of a chest twinge.
Exactly. It creates a self-fulfilling prophecy of failure for the control group.
So the establishment viewed those early trials as fundamentally biased.
Right. PRAMI was the hammer that shattered the glass because it had the sample size, it blinded the outcome assessors, and it demonstrated a massive reduction in the hardest possible endpoints, deaths and actual myocardial infarctions.
But even with a trial this definitive, the authors themselves dedicate the final paragraphs of their paper to highlighting the massive gray areas that remain.
Science is never really finished.
Let's dig into the 3 major unanswered questions they posed. Question 1. Does this apply to non-STEMI patients?
No, this is a tremendous clinical gray area.
Because a non-STEMI, a non-ST segment elevation myocardial infarction is still a heart attack, But the pathophysiology is often different, right?
Exactly. The artery might not be 100% occluded. It might be 90% occluded with a tiny trickle of blood getting through.
And the EKG doesn't look the same.
Right. The EKG does not produce that massive flashing neon ST elevation pointing directly to the culprit lesion.
To bring back the burning house analogy, the house is definitely on fire, the smoke alarms are blaring, but the smoke is so thick you can't tell which specific room actually started the blaze.
That is precisely the issue. In a non-STEMI with multivessel disease, the cardiologist might look at the angiogram and see 3 different arteries, all with 70% blockages, and have no clear indication of which one is actively showering clots downstream.
That sounds like a nightmare. If you apply the Prami logic and just start stenting everything you see, are you fixing the primary problem, or are you just exposing the patient to the risks of stenting innocent bystander lesions?
We just don't know for sure. Prami's data cannot be cleanly extrapolated to non-STEMAs. It requires its own dedicated large-scale randomized trial to establish new rules of engagement.
Which leads directly into question number 2. The gray area of stenosis severity.
The percentage of the blockage.
Right. The Prami protocol gave doctors a green light to stent any non-infarct artery with a blockage of 50% or greater. But human biology doesn't exist in perfect, round numbers.
No, it certainly doesn't.
What happens when a cardiologist looks at the screen and sees a blockage that is 45% or 48%?
This is the eternal tightrope walk of interventional cardiology. You are constantly balancing the risk-reward curve.
Because putting in a stent isn't free, biologically speaking.
Right. At what exact percentage point do the risks of introducing a permanent metallic implant, the risks of stent thrombosis, the requirement for prolonged dual antiplatelet therapy, and its associated bleeding risks, outweigh the physiological benefit of increasing the vessel lumen?
If a smoldering room only has a tiny wisp of smoke, do you risk massive water damage to the house by turning the fire hose on it?
Great analogy again. Prami definitively proved that at 50%, the risk-reward ratio massively favors stenting, but at 45%, the data is totally silent.
And the complexity of that question is compounded by the third issue the authors raise, which is how we actually measure that percentage in the first place.
Right, the visual versus physiological assessment.
Throughout the PREMA trial, the cardiologist determined if a blockage was 50% through visual estimation.
They literally just looked at the two-dimensional shadow of the artery on the angiography screen and eyeballed the plumbing.
But the author suggests the future lies in FFR, which stands for fractional flow reserve. Let's explain the physics of FFR, because it completely changes the paradigm from a visual assessment to a physiological one.
FFR is a quantum leap in diagnostic accuracy.
How does it work?
Instead of relying on a visual estimate, the cardiologist threads a microscopic wire equipped with a high-fidelity pressure sensor directly through the coronary artery, pushing it past the site of the blockage.
Okay, so a tiny sensor is past the clog.
Right. Then they administer a drug, usually adenosine, to induce maximum hyperemia.
Hyperemia meaning what?
Forcing the heart to dilate its vessels and demand maximum blood flow. The sensor then measures the exact pressure of the blood distal to the blockage and compares it to the pressure in the aorta before the blockage.
Ah, I see. It's the difference between looking at a kinked garden hose and visually guessing how badly the water flow is restricted versus actually attaching a pressure gauge to the nozzle and measuring the exact drop in PSI.
That's it exactly. It measures the true physiological impact of the lesion. FFR produces a ratio. An FFR of 0.80 means that the blockage is causing a 20% drop in maximum blood flow.
So the authors are raising a brilliant point. What if a visual 50% blockage is actually flowing perfectly fine under an FFR assessment?
Yes. Or, conversely, what if a visual 40% blockage is secretly causing a massive pressure drop?
If we ran PRAMI again, but used FFR pressure gradients instead of human eyeballs to decide which smoldering rooms to treat, would that 65% risk reduction be even higher?
It's very possible, and fundamentally questions whether we're treating the anatomy or treating the physiology.
And there is one final massive logistical debate that PRAMI sparked regarding the timeline of intervention.
The staged PCI approach.
Right. PRAMI compared doing everything immediately during the STEMI versus doing nothing and relying on drugs. But what about the middle ground? What about immediate versus staged PCI?
The staged PCI approach is highly compelling from a physiological standpoint.
Walk us through how that would work in practice.
The theory asks, what if you fix the main culprit artery on Tuesday, saving the patient's life, but then you pause?
You just stop right there.
Right. You send the patient to the cardiac intensive care unit, You let their volatile heart rhythm stabilize. You allow their kidneys 48 hours to flush out the initial load of toxic contrast dye.
You let the systemic inflammation from the ruptured plaque subside.
Exactly. And then on Thursday, in a calm, controlled elective environment, you bring them back down to the cath lab to stent the remaining 50% blockages before they are ever discharged from the hospital.
So you are taking the total trauma of a massive multivessel intervention and splitting it into two smaller, infinitely more manageable physiological events.
Exactly. It sounds incredibly logical, but Pramy did not test that hypothesis.
No, it didn't.
Pramy just proved that comprehensive treatment is superior to minimalist treatment. But to determine if immediate, all-at-once treatment is superior to staged, carefully timed treatment, well, the medical community will have to engineer an entirely new, massive randomized trial.
Which really distills the ultimate takeaway from this deep dive for you, the listener.
It does.
We began this discussion by acknowledging how medical guidelines can feel like immutable laws of physics.
We assume that if the European Society of Cardiology tells a doctor not to do something, it must be because it's inherently objectively dangerous.
Right. But the Pramy trial is a masterclass in critical scientific thinking. It reveals that even the most authoritative, entrenched guidelines are simply snapshots of the best available data at a specific moment in time.
They are educated guesses.
Exactly.
It is a profound lesson in intellectual humility for the entire scientific community. I mean, the minimalists who wrote those conservative guidelines weren't negligent. They were attempting to protect vulnerable patients from acute harm based on the pharmacological data they had at the time.
But science is not a belief system. It is a process.
Right. When a trial like Pramy delivers high-quality, methodologically bulletproof evidence that contradicts the dogma, the entire field has an obligation to update its worldview and change the standard of care.
And as we look forward, the rapid acceleration of technology forces us to confront an even more philosophical question about the future of cardiology.
It absolutely does.
Because if we connect the lessons of Pramy to the broader trajectory of medical science,
We are entering a totally new era. An era where advanced non-invasive imaging and artificial intelligence algorithms are becoming capable of identifying microscopic vulnerabilities and lipid pools in our arteries years or perhaps decades before a plaque ever ruptures or a STEMI occurs.
the Pramy trial proved we should aggressively fix the smoldering rooms during a fire.
But as our technology improves, where do we draw the line between preventative medicine and the overtreatment of the healthy?
Right. If we eventually gain the ability to deploy microscopic scaffolds into every single vulnerable artery before the fire ever has a chance to start, will we finally conquer cardiovascular disease, or will we fundamentally alter what it means to age?
That is a staggering implication that will definitely linger long after this deep dive ends.
Thank you for watching The Funnel Effect.